Dr. Ramanan, that was fantastic. Thank you for the wonderful illustrations and the presentation. This is very dreaded for many of us, especially if you are a non-surgeon, because this is one complication that most of us agree that we cannot manage and is kind of acute. You need somebody to come and help you. One thing that I have continued to struggle with is, when patients present with acute limb and, they don't seem to have a compartment syndrome, but when you're working on them, they complain of pain. Obviously, they're ischemic. And there's a little bit of a confusion in regards to whether there's a compartment or is it ischemia that's causing the pain. And many times I have called my surgical colleagues and they come, they evaluate, they're like, no, Mehdi, don't worry, this is it's fine, go ahead. Can you tell us what you look for? If I were to call you in the middle of the case of a patient that came in with acute limb, how do you differentiate the ischemia from the lack of blood flow versus a true compartment that requires a fasciotomy?
That's a great question. And actually, the answer is it's actually quite difficult. The key things are, one, when someone comes with an acute limb ischemia, what is their exam before we even start revascularizing them? So many times, if someone comes with motor deficits, so if they can't move their leg when they present with an acute limb ischemia, automatically they are at an extremely high risk of developing a compartment syndrome once they get revascularized because of the ischemia reperfusion. So that's something that we keep in our mind, and many times we'll do a prophylactic fasciotomy in these patients when we revascularize them. Even if they don't have compartment syndrome that we feel at the end of the case, we'll do a fasciotomy, because just like the case I presented, 5-10 hours after the procedure, they'll start getting significant swelling, and then they'll have to go back to the procedure for a procedure. The second thing, during the procedure, it depends on what we are able to achieve at the end. So if we are able to achieve a total inline flow, so like in this patient, we got inline flow through 2 vessels to the foot. That, in someone who has come in with a complete occlusion, if we can achieve inline flow and a palpable pulse, those patients are at pretty high risk for getting a compartment syndrome also, just because of the amount of ischemia reperfusion. So post-op, we would, intra-op and post-op, at the end of the case, we would examine their leg and feel the compartments. If we are not able to decide whether that is something significant, then I think an important thing would be to measure compartment pressures. But if we think that there is a pretty high risk of compartment syndrome, I think it's better to do a prophylactic fasciotomy rather than let the patient go on to develop clinical symptoms and then develop nerve ischemia.
Well, thank you so much. I was going to go to Dr. Madaseri. Kumar, I have been at some conferences. I have not done this myself, but some of my colleagues have recommended if you have a perforation that potentially is leading to a compartment, we are not so different kind of a case than an acute limb that's been cooking and is related to reperfusion injury. This is like a perf or something where you've done a tibial-pedal access, and I know you do a lot of that, to do it percutaneously. Have you ever tried this percutaneously yourself? And any thoughts or suggestions around that? What do you do when you're concerned about compartment beyond the percutaneous approach?
Sorry, it cut out a little bit. So you're saying during the percutaneous approaches, what do you do with concern for compartment syndrome? Is that what you're saying?
What I was asking is that, have you ever tried to deal with a compartment hematoma percutaneously? And do you have any experience with that in general?
I appreciate you thinking that I have a lot of perforations, Mehdi. I really appreciate that. Luckily, I haven't had, with all the numbers of tibial have not had it, but I have had, acute limbs have the compartment syndrome. And I think it's a very interesting conversation. I like the pictures that you show. Thank you. I know a lot of people have dealt with it percutaneously. I've not had to yet. I have had perforations in the tibials, but with ballooning and overlying bare metal stents and once or twice your famous graft masters, that's about all I've had to deal with. So I wish I had. I hope I don't have to deal with it percutaneously, but I do have our vascular colleagues always on speed dial with us.
That's wonderful. Let me follow up with the same question to you in regards to what do you do given the number of and volume of tibial-pedal access cases you do? What do you do to make sure that they don't lead to compartment?
So for me, I don't use sheets in my tibial-pedal access. Everything I do is just the wire, and if anything, the inner three of the micropuncture. There's nothing else I put in any of my retrograde accesses. I bareback the 014, 018 microcatheters, and then when I'm done, I'm always reversing the wire and ballooning across it. So to this date, knock on a big piece of wood, you know, I'm always getting hemostasis on the table before the case is done. So, and shooting a delayed angiogram to make sure you don't have a leak, it prevents you from having those situations. So I think if you take those cautious steps, you know, sheets are great. If you want to do TAMI procedures, that's great, but you increase the risk of all this, especially with the heavy anticoagulation. So for me, I avoid it by not having a large access retrograde.
Wonderful. That's great advice. And also, obviously, checking an angiogram before you leave. You should always make sure that everything is sealed before you leave the lab. I was going to go to Chris White. And Chris, you mentioned all the complications with the structural procedures, which, you know, I enjoyed, and I want to follow up on that, on your point. One of the things that I have learned is that in a lot of these cases, especially when they have a thrombosis or clot forming around the sheet or some kind of a groin, you know, closure device issue, that you don't have to make it perfect. That if you're able to balloon it, open up some flow, the patients actually do well, and then you can electively deal with it at a later time. Is that your experience, and any advice you have related to that?
Yeah, so I completely agree with that. I mean, the enemy of good is perfect, right? I think that anybody who's been doing this for any length of time regrets the last balloon inflation, regrets the last upsizing they did, and wishes they had simply settled for a good result. The only other thing I would say regarding the iliac and structural things is that we have a very low threshold for contralateral access. And typically, we are ready to retrograde or integrate across the ipsilateral tear so that we don't have to work through our primary access site. We can actually free the access site and work from the contralateral side in order to tamp it on or think about delivering other devices. So have a low, very low threshold for the contralateral access.
Thank you so much. Bo, you showed a tibial perforation, and I was going to ask you your advice regarding hemostasis in these tibial cases. Do you put a cuff? How do you deal with hemostasis when you do retrograde access, tibial retrograde access, or when you have a perf? Is it just manual, or what else do you use to deal with that?
So for the most part, we've used manual pressure for our distal retrograde tibial accesses, and knock on wood, I've not experienced a lot of bleeding complications with that. You can also use your, your radial hemostatic bands with some modifications down there, and those seem to work relatively well. I think there's another school of thought where after crossing and doing your work retrograde through a tibial access, if you also have an antegrade sheath, you can also just do balloon occlusion of the tibial arteriotomy site, and that seems to work well. So I think it's just kind of your personal preference, but I think for the most part, these distal tibial accesses, as long as you pay attention, do the right thing, and do your good completion angiograms, I think the bleeding risk is pretty low and pretty manageable if it happens.
I was going to go to Mazen. Mazen, we didn't really talk about dissections as a complication, because I feel like in peripheral, dissection is like part of the work we do. We create dissections. But maybe we should, at least get your advice. When do you decide to stent, Mazen, with these dissections that we create? Give us your algorithm. Do you use hemodynamics? Do you use pressure gradients, imaging? Can you help us?
Yeah, so I definitely angiography is important. Try to see how the flow is. You're always limited though by having the wire across the dissection, which may be holding the dissection up. And then when you remove the wires, things get much worse. So it depends if it's antegrade, retrograde, and how big it is, how much, what's the length, what artery it is, and what does the artery supply, especially if it's big iliac and it's going to supply the whole leg. I try to use hemodynamics without using wire. If there's a pressure gradient, I usually like to stem that. And that can be done by using a smaller 014 or 018 wire and just doing a pullback with a bigger 035 catheter. But really the times I've been burned is when you think it's okay, and then when you remove the wire, it shuts down. So that's a little bit more tricky. Sometimes IVUS can help if you see the spiral dissection. This means when you remove the wire, most likely it's going to shut down. So any modalities that can help you will definitely be helpful.
June, you showed a nice case of the kind of thrombosis. Can you give us your algorithm for follow-up? When you have a patient that you treated, now comes back with thrombosis, especially acutely and in such a short time, how often do you see that patient, and what are the imaging or a non-invasive assessment that you usually perform for these kind of patients that are high risk?
That's a great question. For patients that have really recurrent acute limb ischemia, or those that you have a significant amount of stenting, obviously in 2020, most of us try to spot stent, especially just areas that have very focal dissections or areas with very high restenosis rates. So the patients that have essentially what we call a full metal jacket, or those that have a higher risk of acute limb, I actually am a little bit more aggressive about arterial duplex follow-ups. Typically, my routine for patients with claudication is AVI at 3 months and then at 6 months and at 1 year. But for those that are at higher risk of recurrent stent thrombosis, I'm more aggressive in that I actually see them within a month with an AVI, TBI, as well as an arterial duplex, and then at 3 months and then at 6 months. So those patients you really have to keep a close eye on, because what you don't want is the work that you've worked so hard on to fail.
Thanks. And Peter, maybe I ask you, once you do the non-invasive testing, you do the ultrasound, and especially in these kind of patients that have come with recurrent closure, what is your threshold in regards to prophylactic intervention? The patient is asymptomatic, they come at 1 month, they get a duplex, it shows a velocity of 300, 350 at the ostium of the SFA. When do you take the patient back to treat them prophylactically, even though the patient has no symptoms?
That's a great question, Kenny. I mean, we have so far to go in terms of improving our non-invasive management post-procedure of patients in general. A lot of the data that was derived about use of non-invasive duplex post-intervention to guide revascularizations from the surgical data, you know, with the threat of an impending graft going down is one thing, as opposed to the threat of a potential stent going down. Furthermore, atherectomy and drug-coated therapies without a scaffold, probably even less likely if you have flow acceleration to demonstrate some increased risk. The short version is I'm fairly conservative, you know, in terms of decision making with regards to what we see. I'm quite frequently, if I see a new flow acceleration on a duplex in the near term after an intervention, I'll bring that patient back and monitor it. It's been quite interesting. We have a case series of patients post-atherectomy where we've seen some mural wall hematomas that have actually kind of improved over months. And those are folks where you might have seen a doubling of a peak systolic velocity and thought to bring them back if it was inside a graft. So short version, fairly conservative. You know, certainly if I do see something that looks like either an issue with the stent or a severe flow acceleration, especially if it was not treated inside a CTO. So it's someone where if you opened a 80% lesion and turned it into a 0% lesion and now it's threatening to become a 100% lesion, I'd certainly be a little more aggressive in that situation as well.
Yes, I was going to ask Kenny, I know he has to get off, but I want to give him the last advice. Kenny, we're talking about complications. Give us your word of wisdom. We have a lot of young fellows, a lot of early career folks. What we should do in general? What's your word of wisdom?
I'm not sure I have any words of wisdom. Having had many in my day, I would just say, and this is the theme that has been promulgated throughout this, is prepare, expect complications, think about in advance what could happen, what are all the complications could happen, and be ready for them. Get help, surround yourself with expertise, and I don't mean just your associates, but your staff. Have them prepped, and frankly, I think we probably don't do enough to think about that in advance. I'm speaking for myself. You know, I do balloon pulmonary angioplasty, and I've done about 150. But yesterday, for the first time out of 150, I had to intubate somebody because I'd perforated an artery, and it ended up having to coil it. And I'm not, you know, proud of that. I was in the wrong place, but having everything there, equipment, personnel, staff, access, arterial venous access, important, really important for fluid resuscitation, and at your fingertips, it makes a difference of life and death in some instances.
Kenny is the other old guy. Let me just say for young people is you don't want to hide complications. You don't want to deny them. You don't want to pretend that they didn't happen or that they aren't a problem. And I think youngsters get nervous about what that means to have a complication, but you need to sort of embrace it early. And that's the way forward, to solve it early, not to wait until not to deny it and then wait 3 hours later and see that a terrible bleeding thing has happened. So come clean, let others know that you've got a problem, ask for help, as Kenny said, but sort of embrace those complications. Don't put them under the rug.
Let me ask one other question. Subhash gave me a couple more minutes. I can go over if that's okay with you guys. There is a lot of folks. We have over 500 people watching this. So I want to ask Dr. Sai, Sherlyn Sai, and this is a little bit, you know, I always ask some of these political questions, but as a vascular surgeon, and we have a lot of interventional cardiologists and interventional radiologists on the call. What is it, how can, like I am new in a hospital and I am worried, I don't know the surgeon. What's the best way for an interventional cardiologist or an interventional radiologist to build, amend relationship with a vascular surgeon so that if they do have a complication, they're comfortable reaching out? What, I guess what I'm asking, let me put it simple. What annoys you and what makes you happy to be able to work? And forget about Subhash, you don't have to be political because he's on. Just tell us what you feel.
No, I actually, I mean, first of all, vascular surgeons are not bad people. We're generally quite nice. And I'm actually very lucky to work with someone like Subhash, and you know, I worked with Dr. Brolakis and Dr. Alaidi. I mean, they're just great. I think it just has to be a very collaborative atmosphere. I mean, we all have access site complications, and so I would never fault anyone to have an access site complication because it happens. This morning I did an EVAR, and on the second access, I opened the cut down tray for the eventual access site complication because it happens. So that's the first thing. And then, you know, a lot of these, if you look at the you know, the clinical exam or the pre-op imaging or something, and it looks like it's going to be a difficult access, I think it's nice to just tell us that, you know, we're going to have there's a potential for a problematic access, and, you know, we'll be prepared for it. But, you know, just call us early, and you know, you're generally pretty happy to help. It happens to everyone.
Mehdi, I want to jump here and just say that, and I don't want to speak for Bala or Charlene, and I've already said I'm fortunate to have them, but the real, I think this puzzle is actually settled by case discussion and pre-planning. I think Charlene mentioned it, and we are proud to have those kinds of discussion pretty much on a daily basis. I mean, we really exhaustively review the images and have a discussion pre-procedure. And if there is a acute case that we need Sherling's or Bala's help, I'm actually not shy to call them and have them review some of the cases in the lab. So I think that kind of communication is probably the best, and think the surgeon gets a sense that the interventional cardiologist or the new faculty or the new attending is thoughtful, is planning for the cases, and is not shy to share their limitations. Dr. White said something of great importance, that we should not try to hide our limitations or even our complications. I think that makes us better, stronger, and builds stronger teams, and it's good for the patient overall. So I'm all for, I think, full disclosure and discussion.